Good afternoon, everyone. I hope you all had a nice Christmas and New Year break, and we're all ready for the winter storm and getting frozen in. So we're happy to kick off the 2025, endocrinology Grand Round series. And because of the weather, we decided to have it remote for this week, as it would be more difficult for people to come downtown and get back to wherever they wanted to be. So we're happy to have today, to start off 2025, our own junior faculty member, Dr. Zach Sibai, present. He joined us, I think, about 4 years ago, um, as a fellow, and after completing his endocrinology fellowship in 2022, he joined our faculty and has been very successful, has been a great clinician and educator, has had presentations here, and also worked with our fellows to present at regional and national meetings. He has been a great educator in terms of helping the fellows with their board preparations, and glad to let everyone know that our fellows did clear their board. So thanks to his efforts, in addition to all the other faculty. So today he's going to talk to us about primary aldosteronism from screening to treatment. Thank you, Dr. Sibai, for bringing up this very interesting and important topic.
Okay. Thank you so much, Dr. Moksha. Just to make sure that my voice is clear. And thank you, everyone, for attending our endocrine grand round today. And I'll be happy to discuss today primary aldosteronism Conn syndrome from screening to treatment. Please feel free to interrupt me while I'm talking in case you have any question or for any clarification. So I'm going to start first with I'll start with a case presentation. This is a patient that we encountered back in September during inpatient consult. And he's a 38-year-old male with a past medical history of non-ischemic cardiomyopathy with reduced ejection fraction 35%, ventricular tachycardia, TIA and CVA back in 2019, sleep apnea, chronic kidney disease, stage 2, hypertension, and hypokalemia. He presented to the ED with, unfortunately, intentional medication overdose with Entresto, isosorbide dinitrate, and hydralazine, but we're not sure how many pills he took. And it was an attempt to kill himself because he recently lost his job and he has been going through a really tough social problem. So when he presented, he has been having some symptoms of bilateral hands, numbness and tingling, feeling nauseous with abdominal pain. Review of home medication, just to know exactly what he has at home. He has aspirin, 81 milligram, prednisone, amiodarone, atorvastatin, carvedilol, Entresto, hydralazine, isosorbide dinitrate, potassium supplement, and Lasix. So mainly medication for cardiomyopathy, heart failure, potassium supplement, and hypertension. So in the ER, his vitals were stable. They did AKG, which shows polymorphic PVCs, and his initial labs as the following. There's really severe low potassium of 1.8, plus we can see some mild hyperglycemia, and there's a decrease in the GFR compared to his baseline, plus low magnesium. So giving his presentation and his blood work, he was admitted to the medical ICU, and he was started on potassium magnesium supplements, put on cardiac monitoring, and his heart failure medication were stopped. Psychiatry was consulted, nephrology was consulted for his AKI and IKI, and he was started IV fluids. And endocrine was consulted also because of his history of hypokalemia and possible hyperaldosteronism. So the patient reported that he's been diagnosed with hypertension and low potassium for almost 5 years. And in the past, he was on spironolactone for more than a year, but it was stopped due to gynecomastia. And a couple of months ago, he was started on eplerenone. He denied any family history of resistant hypertension, any history of hypokalemia, or any adrenal problem. When reviewing his outpatient and inpatient records from previous hospital visit and previous clinic visits, looks like he was following with cardiology and nephrology as an outpatient. And also he had like a recent hospital admission for severe hypokalemia almost a couple of months ago as well. So when looking to his blood work from that admission, also he had a pretty low potassium level of 2.3, and looked like someone's tried to look for hyperaldosteronism back then, and he had a really high aldosterone level of 30, pretty low renin suppressed, and aldosterone renin ratio of above 181. So blood work really consistent with primary hyperaldosteronism. Also, he had a CT scan of the abdomen and pelvis back in also like in 2024, and it shows left adrenal nodules, measured 2.7 centimeter, and it has approximately Hounsfield unit of 11 on pre-contrast imaging. The right adrenal glands was stable in appearance. So in a couple of days during his inpatient care, after a couple of days, he was stabilized, potassium level like around 3.8 to 4, and he was on potassium chloride 80 milliequivalent 3 times a day. He was stable from cardiac and renal standpoint. Some of his heart failure medication were resumed, and then endocrine surgery consulted for surgical treatment for his hypaldosteronism. So based on his medical history of hypertension and hypokalemia, looking to his labs of consistent with hyperaldo, and imaging study which shows left adrenal adenoma, he was diagnosed with primary aldosteronism due to aldosterone producing adenoma, which is known as Conn syndrome. So the patient underwent, after a couple of days after we get cardiac and renal clearance, he went for left adrenalectomy without any complication. Of course, potassium supplement were stopped immediately after the surgery. AM cortisol the next day was normal, and his labs were monitored daily. So looking to the trends of his blood work on day 1, 2, and 3 after surgery, his potassium level was kind of trending down to lowest 3.4. Some decline in the kidney function, which is expected after treating hyperaldo surgically. But the patient was ready for discharge, and on discharge, he was instructed to stop taking hydralazine, azoxystrobide nitrate, and Entresto, eplerenone, because his blood pressure was very well controlled, and also because of his decline in GFR. He was advised to continue some of his heart failure medication by cardiology, like carvedilol and pometanide. And also he was advised to resume potassium supplements, only 40 milliequivalent BID. So as an outpatient, he had the lack of blood work 1 and 2 weeks after the surgery, and his potassium level was 4.6. Blood pressure was well controlled. And looking back again to his aldosterone was kind of normalized, was a bit low. Renin 0.3, and aldosterone ratio is normal. So this is kind of like a classical case of primary aldosteronism due to aldosterone producing adenoma, which is managed with surgical treatment with very good outcome, with normalization of potassium, less number of hypertension medication, and his aldosterone renin kind of start to normalize. So for today's presentation, we're gonna describe primary aldosteronism. We're gonna go over in quick regarding the etiology, pathophysiology, clinical presentation, and epidemiology. And then we're gonna go over the diagnostic approach for primary aldosteronism, from screening until confirmation tests, and then go to the surgical options and medical option treatments for primary aldosteronism. And then at the last, we're gonna go over the outline, prognosis, and long-term outcome. So primary aldosteronism is a condition of inappropriate excessive secretion of aldosterone from one or both adrenal glands, which is causes due to different adrenal gland etiologies, and leads to hypertension, hypokalemia, and also increase the risk of long-term cardiovascular and renal complications. Right now, primary aldosteronism is considered the most common cause of secondary hypertension. The first case of hyperaldosteronism was presented by Dr. Jerome Conn, who's an endocrinologist at University of Michigan. Back in 1955, he presented a first case of a female woman who had a history of weakness, transient paralysis, muscle spasm for about 7 years. With further evaluation, they found she had like severe hypertension, hypokalemia, and she also has increased urine aldosterone excretion, and also she had like a right adrenal tumor. And her symptom resolved, and she was cured following adrenectomy. So moving to the etiology of hyperaldosteronism. As we mentioned before, hyperaldosteronism is a status of increased aldosterone secretion from the adrenal, which could happen due to different etiologies. This is the table summarizing the most common etiologies. The second most common is aldosterone-producing adenoma, which is known as Conn syndrome, 30%. Bilateral hyperplasia, 60%. Unilateral adrenal hyperplasia, about 2%. Very rare cases of primary aldosteronism due to aldosterone-producing adenocortical carcinoma, less than 1%. And also there's some genetic reason for hyperaldo, like familial hyperaldosteronism, which has 4 different types. And usually the familial causes and genetic causes usually suspected in patient who has resistant hypertension or hypertension when they are less than 20 years old. And all these different subtypes is due to like a difference in genetic mutation, which lead to like a different alteration and in the aldosterone production and synthesis pathway. So just one slide about the physiology of aldosterone mechanism action. So we know aldosterone is secreted from the adrenal cortex, from the zona glomerulosa. It's usually secreted by secretion is regulated by renin and potassium level. And aldosterone function mainly works on the principal cells in the distal tubule and collecting duct in the kidneys to cause sodium and water reabsorption to the bloodstream, and also at the same time potassium excretion to the urine. So when there is an abnormal increase in the aldosterone secretion from the adrenal glands, independent of renin and potassium level, this is going to cause excessive sodium and water reabsorption to the bloodstream, which is going to lead to an increase in the intravascular volume expansion and lead to hypertension. At the same time, also is going to lead to increased potassium renal excretion and was going to cause hypokalemia. And usually they are the hypokalemia and the hypertension are the hallmark of primary aldosteronism. But do all patients with primary aldosteronism have hypokalemia? So the answer for this question, we can answer it from this study, which looks for the prevalence of hypokalemia and primary aldosteronism in 5,100 patients referred to a tertiary hypertension unit. And they found that the prevalence of primary aldosteronism in their cohort was 7.8%. And when they look into the prevalence of hypokalemia in patients with primary aldosteronism, the hypokalemia was 57% only. So not all patients with primary aldosteronism will end up having hypokalemia. About 43% did not have any hypokalemia. At the same time, not all patients with hypokalemia have primary aldosteronism. Only 28% of the patients who has low potassium turned out to have primary aldosteronism. And also they mentioned that the prevalence of primary aldosteronism is usually increases by the decrease of the potassium level. Moving to the epidemiology, the prevalence of primary aldosteronism is usually between 5 to 15% in patients with hypertension. But also it has been noted that the prevalence is even more higher in patients with resistant hypertension. So in this study, look into the prevalence and the clinical manifestation of primary aldo in the primary care unit. They have a cohort of almost 1,600 patients with hypertension, and they found about 5.9% they have primary aldosteronism. But when they look to the prevalence of primary aldosteronism by subtypes, by hypertension stage, they found that patients with stage 1 hypertension, they have approximately 3.9% prevalence of primary aldosteronism, compared to a patient with a stage 3, they have prevalence of primary aldosteronism about 11.8%. So they concluded that the prevalence of primary aldosteronism increases with the severity of hypertension. And of course, this results and this finding was observed also in different clinical trials. So the question is, who should be tested and screened for primary aldo? So the Endocrine Society Clinical Practice Guidelines back in 2016, they have 7 groups of patients who can be categorized as high prevalence of primary aldo. The first group are patients who has sustained blood pressure above 150/100. The second group, hypertension above 150/90, resistant to a 3 of hypertensive medication, including diuretics. Group 3, controlled blood pressure less than 140/80 on 4 or more antihypertensive medication. Patient with hypertension and spontaneous or diuretics-induced hypokalemia. And then patient with hypertension and adrenal incidentoloma. Patient with hypertension and sleep apnea. And lastly, patient with hypertension and also have a family history of early onset hypertension or cardiovascular accidents at the younger age, less than 40. So when I was looking to this table, most of this group were kind of make sense, but except the 6th group, I was trying to ask myself, like, what's the association between sleep apnea and primary aldosteronism? What's the specific reason that we should screen patients with hypertension and sleep apnea for primary aldosteronism? So I'm just going to spend a couple of slides to discuss these points. So it's been known that individuals with moderate to severe sleep apnea are more likely to have hypertension compared to individuals similar in age and body weight without sleep apnea. And also there's a positive correlation between the severity of sleep apnea and the level of blood pressure. More severe sleep apnea, the higher the likelihood of having severe hypertension. So recognizing the fact that both sleep apnea and hyperaldosteronism are common in patients with hypertension, some researchers, they hypothesized that possibly they two may be related to each other, and with one contributing to the development of the other. So multiple clinical studies looked at the prevalence of primary aldosteronism in patients with hypertension and sleep apnea. So this is a study done back in 2010, and they look into a total of 325 patients who have been diagnosed newly with hypertension, and they were evaluated for sleep apnea and primary aldosteronism. And they found that primary aldosteronism prevalence was 10% in patients with hypertension without sleep apnea and 25% in patients with hypertension and sleep apnea. So they mentioned that there's high prevalence of primary aldosteronism in patients with sleep apnea, and we can conclude that patients with hypertension and sleep apnea, especially those who are newly diagnosed, must be evaluated for sleep apnea. There are multiple studies look into the same goal to see if there's an association between prevalence between patients with sleep apnea and without sleep apnea. And this study showed that primary aldosteronism prevalence was 34% in sleep apnea patients compared to 9.8% without sleep apnea, 32% in sleep apnea patients compared to 8% without sleep apnea. Not only, this is another study also back down in 2010, but the main goal of this study is to investigate and examine the relationship between the aldosterone status, high or normal, and the severity of sleep apnea in patients with hypertension. So trying to see if there's correlation between the severity of sleep apnea with aldosterone level. So they had 109 patients who has been diagnosed with resistant hypertension, and they evaluated them for aldosterone status by obtaining plasma renin activity, 24-hour urine aldosterone excretion, and they did the sleep study. And those patients were divided into 2 groups depending on their aldosterone status. First group is high aldosterone status with renin, plasma renin activity less than 1, and elevated 24-hour urine aldosterone above 12, and they have a total of 31 patients. The second group is normal aldosterone status, who has normal aldosterone above 1 and less aldosterone in the urine, which is less than 12 over 24 hours. And they have a total of 78 patients. So comparing the sleep study result for those 2 groups, they found that the high aldosterone status, they have worsening or severe sleep apnea based on the apnea index, which was severe and high aldosterone status of 27 events per hour compared to 17.5 events per hour in normal aldosterone status. The hypoxia index was more severe in the high aldosterone group, 10% compared to 6.2%. The mean oxygen saturation was lower, 93% compared to 95%. So they concluded that the severity of sleep apnea was greater in high aldosterone versus normal aldosterone group. So there's a question been asked, which is about what's the mechanism between the association between aldosterone excess and increased severity of sleep apnea. But actually, the underlying cause is not very well understood, but there's a hypothesis that possibly aldosterone causes increase in fluid retention, some of which is located in the neck, leading to parapharyngeal edema and increase in the upper airway resistance. Actually, there are some groups that tried to treat sleep apnea patients with eplerenone and spironolactone. So this is a study that looks at the effect of eplerenone on the severity of obstruction sleep apnea and arterial stiffness in patients with resistant hypertension. So they had a total of 31 patients with hypertension and sleep apnea, and they were treated with eplerenone for 3 months. And they did sleep study before and after, and they compared the results before eplerenone and after eplerenone, and they found there's improvement in sleep study results. Looking to the apnea index, which was 90, apnea index was 32% compared to 15%. Hypoxia was 11%, went down to 8.2%. Oxygen desaturation index was 39%, went down to 27%. Mean saturation went up from 89% to 93%. So they concluded that there's a clinical significance of eplerenone, not only in treating hypertension, but also as a drug that may reduce the severity of sleep apnea and arterial stiffness in patients with resistant hypertension and sleep apnea. I just want to mention that in this study, they did not test for primary aldosteronism. They're just treating patients with sleep apnea and hypertension with eplerenone, regardless of their aldosterone status. And there's another study was done testing spironolactone on severe sleep apnea severity, and it shows like improvement in sleep study after starting spironolactone. So as a conclusion, we can tell that sleep apnea and primary aldo are both common in patients with resistant hypertension. Primary aldo are more common in hypertensive patients with sleep apnea compared to without sleep apnea. There's evidence of association between aldosterone excess and sleep apnea. Also, there's possible evidence of positive correlation between the degree of aldosterone excess and the severity of sleep apnea. And lastly, there are small studies show that aldosterone blockade, like spironolactone and eplerenone, can reduce the severity of sleep apnea in patients with resistant hypertension. So based on all these studies, I think one of the reasons that the Endocrine Society recommends to screen for primary aldosteronism in patients with hypertension and sleep apnea. So moving to the diagnostic approach for primary aldo, which is consistent with 3 steps. The first step is a screening or case detection test. Second, it's the confirmation test, and then the subtype evaluation. The screening or case detection test is usually done by the aldosterone-renin ratio, which is currently the most used test for primary aldo screening. Usually this test requires the measurement of serum aldosterone concentration, which is expected between normal to elevated, and plasma renin activity, which is expected to be low. But there are some limitations for using aldosterone-renin ratio as a reliable test for primary aldosterone screening. And we're going to over 3 limitations. The first limitation is what is the diagnostic cutoff for aldosterone-renin ratio screening test? When you look to the criteria and the interpretation of the aldosterone-renin ratio, we can find there's different cutoff has been used to interpret the results. Some group or some guidelines, they use the aldosterone-renin ratio above 40, which is more conservative. Compared to other guidelines, they use a more permissive ratio of more than 20. So there's no like really consensus or clinical data that validate what is the aldosterone-renin ratio cutoff as a more sensitive and specific, give us the most sensitive and specific results. Second limitation of this test, that aldosterone-renin ratio is mathematically highly dependent on plasma renin activity, which means if we have low renin value of, let's say, less than 0.1, and the aldosterone-renin ratio will be elevated even when plasma aldosterone is low and is almost certain not consistent with primary aldosteronism. For example, if you have a patient with renin level is very low, like 0.1, and serum aldosterone is 4, we're going to get a ratio of 40. That's a really high aldosterone-renin ratio, but the serum aldosterone is low, which is kind of not consistent with primary aldosteronism. For that reason, some investigator, they suggested to include minimum aldosterone level within that screening criteria. Going back to this table, we can say some investigators suggested a minimum of aldosterone above 20. Some use a criteria of above 15 and others above 6. So giving all this variation and interpreting the results, actually there's no like really consensus on the interpretation and the cutoff values of the screening test of primary aldosteronism. But we can tell if the aldosterone-renin ratio less than 20, and if the aldosterone less than 5, or the plasma renin above 1, those results are consistent with negative tests, and we can rule out primary aldosteronism. So mainly we should not only look into one number like the ratio and make interpretation, we look into the ratio, serum aldosterone, and plasma activity before we go into second step, which is the confirmation test. And the last limitation I want to mention, that there's multiple factors and medication can affect aldosterone and renin level and could cause false positive or false negative aldosterone-renin ratio results. For example, there are potassium-sparing diuretics, potassium-wasting diuretics, ACE, ARBs, and calcium channel blocker. All of them can affect aldosterone and renin level in a different way, at the end lead to low aldosterone-renin ratio, which is going to cause false negative results. On the other hand, beta blocker, central alpha agonists like clonidine and NSAIDs, also they can affect aldosterone-renin level and could cause false positive aldosterone-renin ratio. Other factors could affect the blood levels are hypokalemia, which could cause aldosterone to go down and renin to go up. As a result, we're going to get false negative screening test aldosterone-renin ratio. Also, aging. Patients with age above 65, they normally has lower aldosterone, normal renin compared to younger patients, and those patients may have false positive results. Putting all that together, it's important also to know that aldosterone-renin ratio testing is more sensitive when the samples are collected in the morning, after the patient has been out of bed for at least 2 hours, and usually after he's been seated for 5 to 15 minutes. Those are like a list of medications that are usually safe to use during evaluation for primary aldosteronism, and usually they have a very minimum effect on aldosterone-renin level. The first medication is verapamil, hydralazine, and also alpha blocker. Those medications can be used, and we don't expect much effect on aldosterone-renin level, and we expect to have like a more accurate interpretation for the aldosterone-renin ratio. So once the screening test is positive, then we can go to the next step, which is to proceed with the confirmation test. But there's one exception. That patient who met the following criteria, which is spontaneous hypokalemia, suppressed renin level very low, and aldosterone level above 20, as per Endocrine Society guidelines, those patients, there's no need to go for confirmation test, and they can proceed with the third step, which is subtype evaluation. I really couldn't find like any clinical trial or any data to support this recommendation. But on this situation, we can skip the confirmation test and we can go for the subtype evaluation, because those patients usually considered they have like a really positive hyperaldosteronism. does not require conformation, which is kind of a similar criteria for the patient that we just presented. Regarding the conformation tests, I'm just going to go over it in quick. Usually we have 4 different procedures we can use for as a conformation test, and all of them have kind of the same concepts. We try to suppress aldosterone level in different way, and if the aldosterone level doesn't suppress below a certain point, that's consistent with hyperaldo. The first test is oral sodium loading test. The second one, saline infusion suppression test, fludrocortisone suppression test, and captopril suppression test, or captopril challenge test. The choice of confirmatory tests is commonly determined by the cost, by the patient's compliance, by the lab routine, and the local expertise. There's no superiority one over the other, and usually we can use either one. But usually the most common used one are the first and the second one. So in general, with oral sodium loading test, the idea that we're going to give the patient high salt diet, which is consistent of about 5 to 6 grams per day for 3 days. And then on day 3, we're going to collect 24-hour urine aldosterone level. And if the aldosterone level above 12 to 14, that consistent high after a high sodium diet, which is makes primary aldosteronism is likely. The second test is the saline infusion suppression test. Also, we try to give the patient 2 liters of normal saline over 4 hours. And after completion of the infusion, we check post-infusion plasma aldosterone level. And if the aldosterone level below 5 nanogram per deciliter, that's consistent with negative confirmation test, and primary aldosteronism is unlikely. If the aldosterone level after infusion more above 10, that's make primary aldo high likely. Result between 5 to 10, this is called indeterminate. Then we have a fludrocortisone suppression test. Patient usually give 0.1 milligram fludrocortisone every 6 hours for 4 days. And then we check aldosterone level. And if the level above 6 and renal level is suppressed, that's confirmed consistent with positive confirmation test. And the last one is the captopril challenge test, where the patient gets 25 to 50 milligram of captopril orally, and then we check aldosterone level 1 and 2 hours after that. And if there's a decline or suppression, 30% suppression of aldosterone from baseline, while renin remain unsuppressed, this is consistent with positive tests. So moving to the last step of the evaluation, which is the subtype evaluation, which is considered the key step in distinguish between unilateral and bilateral primary aldosteronism. Also, it's a very important step for deciding on the treatment plan. As we know, unilateral primary aldo is best treated with surgery, adrenectomy, while bilateral primary aldo requires lifelong medical treatments. Usually the first step for subtype evaluation by getting a CT adrenal, and the main indication to get it to exclude any large masses that may represent adrenal cortical carcinoma. But regardless of the finding of the CT scan, if we get like any unilateral adenoma or bilateral hyperplasia, it does not predict or confirm primary aldosteronism subtype. It just only can help us to rule out any big mass that could indicate carcinoma, but it does not help for subtype evaluation. And we'll need to do adrenal vein sampling, which is the gold standard step for disease subtype evaluation, and able to differentiate between unilateral disease and bilateral disease. So I think this is a study was done back in 2012. It's a retrospective study looking into 263 patients who underwent unilateral adrenectomy for treatment for primary aldo based on adrenal vein sampling, and they looked to the accuracy of MRI and CT scan in detecting unilateral adrenal disease, and it was 58%, which is low compared to adrenal vein sampling, which is 57%. But they found out that patients younger than 35-year-olds and younger, the CT scan and MRI were 100% concordant with adrenal vein sampling results. So based on this finding, just want to mention that the total number of patients that they studied here, less than 35, was only 6 patients, so that's a lot. But even though they put in the recommendation in the Endocrine Society that patient with confirmed hypoaldosteronism with CT scan finding of unilateral adrenal lesion and age less than 35, they don't need adrenal vein sampling and they can go to surgery right away. There's another group in 2018, they tried to verify the result of the previous study by doing like a bit of larger one. So also they did retrospective study for 358 patients with primary aldo. 30 patients aged less than 35, 39 patients between 35 and 40, and 289 patients aged above 30. And the main outcome, accuracy of CT finding in determining is determined by adrenal vein sampling finding and or surgical outcome in patient less than 35. So when looking at those 30 patients younger than 35-year-olds, they found 37 patients has unilateral lesion on CT scan, and all found to have unilateral disease on adrenal vein sampling, which is consistent with 100% concordance between CT and adrenal vein sampling results. 3 patients had bilateral lesion on CT scan, and then also found to have unilateral disease on adrenal vein sampling. So their conclusion, primary aldosteronism patients younger than 35-year-olds with hypokalemia and elevated aldosterone and unilateral disease on CT scan could be spared from adrenal vein sampling. So the adrenal vein sampling, the idea of this procedure is to obtain blood from the right adrenal vein, left adrenal vein, and inferior vena cava below the renal vein to measure aldosterone and cortisol level. The success rate of this procedure between 75 to 95. And usually the catheterization of the right adrenal vein is more challenging compared to the left one due to its smaller size and it's because of its anatomic location. Most of the time, the procedure is usually done with continuous co-centromet infusion. And the main reason to give co-centromet, there's multiple reasons, but the main reason is to maximize the gradient in cortisol level between adrenal vein and IVC. So the way we interpreted the results, the first step, we need to make sure that the catheterization was successful for the right and left adrenal vein, and usually evaluated by calculating the right and left adrenal vein cortisol to IVC cortisol ratio. And if the ratio of 5 or higher is confirmed successful catheterization. The second step is to look for lateralization, and this is usually done by comparing aldosterone cortisol ratio between the right and the left adrenal vein. If the ratio above 4, this indicates unilateral disease. If the ratio less than 3, indicates bilateral aldosterone hypersecretion. Any value between 3 or 4 is called indeterminate. So I have like a quick example of one of my patients who underwent for adrenal vein sampling after confirming primary aldosteronism, just a way of practice. So his aldosterone level from the IVC was 37, right adrenal vein and left adrenal vein 800 and almost above 1,000. That's clearly a ratio above 5, which is confirmed like a successful catheterization for both right and left adrenal vein. Look into the aldosterone level. From the right side, aldosterone to cortisol ratio was 0.1. Aldosterone cortisol ratio on the left side was 1.9. There's significant high aldosterone on the left side compared to the right side. So look into the ratio between left and right. 1.9 divided by 0.1 is almost 17, which is above 4, which is consistent with the lateralization to left adrenal disease. So the reason we use 4 as a cutoff for interpretation of adrenal vein sampling is just because it has been shown using the cutoff of 4 has the highest sensitivity and specificity to differentiate between adrenal adenoma, bilateral hyperplasia, and unilateral hyperplasia. So the adrenal vein sampling provides definitive localization of adrenal secreting tumor, but it's invasive, technically challenging, high cost, and sometimes is not available. For this reason, there's a new functional imaging techniques shows promising potential in transforming the diagnosis of primary aldosteronism. And the most common used one right now is gallium-68 pentixafor PET scan. So this PET scan uses a radio tracer ligands for CXCR4 in a PET imaging to visualize aldosterone-producing tumors or aldosterone-producing tissue. So what is CXCR4, which is a transmembrane G protein coupled receptor? The expression of this protein has been found in immunohistochemistry to be upregulated in aldosterone-producing tumor, but is almost negative in non-functional adenomas. And this is a picture of histoimmunoassay, shows positive stain for CXCR4 and aldosterone-producing tumor compared to non-functional adenoma. So this is how the result looks like for a patient with right adenoma, positive uptake here in the right adrenal. The left adrenal, also here different patients, positive uptake. Patient with bilateral adenomas also has a positive uptake in both sides, right and left. Patient with idiopathic bilateral hyperplasia, also there's a very minimum uptake in the both adrenal glands. Compared to the non-functional, it was negative uptake. So although the initial studies are promising, but further research is needed to fully validate its efficacy and establish standardized protocol for widespread clinical use. I'm just going to go over quick regarding surgical treatment, which is indicated in patients with unilateral disease and usually done by laparoscopic adrenectomy, which is the optimal treatment. Usually post-op care consisted with stopping all potassium supplements and to monitor blood work weekly for 4 weeks. Also, it's recommended to measure aldosterone level in day 1 post-op, as suppressed aldosterone level less than 1 predicts biochemical cure. Also, we expect to reduce blood pressure medication and doses by 50% or more, but the full impact of surgery on hypertension may take up to 3 to 6 months. Regarding pharmacological treatment, which is indicated in patients with bilateral disease or patients who are not willing to go for surgery or not candidate for surgery, usually the treatment of choice is using mineralocorticoid receptor antagonists, MRA. Spironolactone is the treatment of choice, starting dose 25 to 50 milligram daily with a max daily dose of 400 milligram daily. Usually we titrate the dose every 4 weeks. The goal of treatment is to obtain potassium level above 4 without supplements, and also to achieve unsuppressed renal level above 1. Side effects are known: erectile dysfunction, gynecomastia, decreased libido in male, and also menstrual irregularity in female, because spironolactone is known also to have androgen progesterone receptor antagonist. And usually gynecomastia is usually dose dependent. On patients on 50 milligram, usually the prevalence about 6.9 milligram, go up to 52% in patients on 150 milligram dose. So it's dose-dependent side effects. Other medication can be used as epinephrine, which is more selective mineralocorticoid receptor antagonist without androgen progesterone antagonist effect. Initial dose 25 milligram BID, and also we titrate the dose every 4 weeks, but it has a 50% less potency compared to spironolactone. The goal also again to keep potassium level above 1 without supplements and to unsuppress renal level to above 1. Side effects, some CNS side effects like dizziness, headache, fatigue, diarrhea, hypertriglyceridemia, and elevated liver enzyme. And the last medication, which is less common medication used, which is amiloride, which is a potassium-sparing diuretics. The dose between 5 to 10 milligram, although it's less effective than spironolactone, but usually it's way much more tolerated in regards to side effects. So going to the last topic for presentation is why it's important to recognize primary aldosteronism and differentiate it from essential hypertension. So it's known that primary aldo is important. It's not only important because of its prevalence as the most common cause of secondary hypertension, but also because primary aldo patients known to have higher cardiovascular and renal complication and higher overall mortality compared to a patient with essential hypertension. Primary aldo cardiovascular complication consistent with AFib, left ventricular hypertrophy, systolic and diastolic heart failure, coronary artery disease, and stroke. Renal complication includes renal fibrosis, CKD, proteinuria, and end-stage renal disease. So treating primary aldo with either surgery or medication, it helped to resolve hypokalemia, help to lower blood pressure, and also can help to reduce the risk of cardiac and renal function impairments. So looking to the difference between primary aldosteronism and essential hypertension regarding cardiovascular events, comparing 124 patients with primary aldo and 465 patients with hypertension, follow this patient for the long term. Patient with primary aldo has higher prevalence of stroke, 12.9 compared to 3.4, more prevalence risk for myocardial infarction, same for AFib, and also for left ventricular hypertension. Same thing, another study comparing patient with primary aldo and hypertension, and this study also showed there's increased risk for AFib, risk of 3.9% in primary aldo compared to 1.1. Same thing for non-fatal myocardial infarction, coronary artery disease, and heart failure. This is like a larger study looking into the mortality in patients with primary aldo. This is a Swedish national-wide study, and the objective of the study is to determine all cause and cause-specific mortality in population-based cohort of patients with primary aldo. So this is like a national register to identify patients with diagnosed primary aldo between 1997 and 2019, and they have a total patient of 2,419, and a control group with hypertension of total almost 24,000. And when following these patients, they found that all-cause mortality was higher in patients with primary aldo of 14.3% compared to 11.3%. And also all causes of specific mortality was higher. Cardiovascular disease, coronary artery disease, and stroke was higher in primary aldo patient compared to the controlled patient with hypertension. So we already established that patient with primary aldo has high risk for cardiovascular complication, renal complication, and more mortality rate compared with essential hypertension. But how does primary aldosteronism management with minorcorticoid antagonist or surgery affect this long-term complications and mortality? So outcome studies suggest that the optimal treatment for primary aldo is surgery therapy to eliminate the source of inappropriate aldosterone production. And patients who are treated with surgery has been shown to require less follow-up. They achieve better quality of life score and have superior cardiovascular risk reduction when compared to a patient who was treated medically with MR antagonists. So this is like a meta-analysis study looking to compare the clinical outcome in patients treated with primary aldosteronism over time with surgery and medication. So looking to different study, surgical treatment shows favorable outcome in regard all causes of mortality with lower risk of 0.34 compared to medical treatment. Same thing, surgery shows favorite outcome in regards major adverse cardiovascular events with less hazard ratio of 0.55. So clearly surgery is superior to medication if we have the option to do surgery. Look into the renal outcome. Look into the renal outcome in patients who was treated medically and surgery for primary aldosteronism. So this is a retrospective study. Look to a patient with primary aldo who are treated with medically with minorcorticoid receptor antagonist 400, and 120 patients treated with surgery, and also a control group with hypertension of 15,000. And the primary outcome looked to the incidence of CKD, which is defined as decline in GFR below 60. Although the three groups had the same blood pressure control over the 10 years regarding systolic and diastolic, they found out that patients with primary aldo who has been treated with minorcorticoid receptor antagonist have higher incidence of chronic kidney disease, lower followed by essential hypertension, and the lower one was primary aldo who has been treated with surgery. Even when looking at GFR decline over time, patient who has been treated with surgically they preserved their kidney function for longer time. There's a more decline in patient with essential hypertension, with even further decline in patient with a primary aldosteronism who has been treated with medication. So they concluded that medical therapy with MRA therapy in primary aldo is associated with a high risk of developing chronic kidney disease when compared to essential hypertension and surgical treated patient with adrenectomy. Actually, the same group of investigator, they look onto the mortality and the mortality rate in patients who has been treated with primary aldosteronism with medication compared to essential hypertension. And they found out that the mortality and the cause of cardiovascular event was higher in patients who has been treated with mineralocorticoids for primary aldo compared with a patient with essential hypertension. But the important point that when they kind of categorize the patient with primary aldo into two groups, one group who has treated with mineralocorticoids antagonists with renin below 1 suppressed, and patient who was having renin level above 1, which is consistent with the optimal treatment, which is the gold treatment, it shows that there's decline in the cardiovascular event, which is almost match the control group essential hypertension. So they concluded, although the medical therapy, possibly it's inferior compared to surgery, but if you're able to optimize the medical treatment to cause enough blockage of the mineralocorticoids receptor with medication, ensuring that renin above 1, we can kind of mitigate this increased risk for cardiovascular events. And this comes to the last slide of my presentation, and today event codes. And thank you so much for your attention. And I'll be happy to have any questions. And also, I'm going to look to the chat box to see if there's any questions. Okay, so it looks like on the chat box, there's no questions. So
So I have a question. Can you hear me, Zach?
Yes.
Steve Winters here, down in sunny, warm Florida.
Good to see you.
That was sorry about that. Anyway, that was very informative and interesting and well done. So congratulations on a good lecture. So I have a comment, of course, a question and a comment which pertains to your interest in the connection between sleep apnea and hyperaldosteronism. And it pertains to the direction of causality between the two findings. So the question is, in your review of that literature, did you find that sleep apnea patients are at risk for adrenal tumors or bilateral hyperplasia? I'll let you come back to it and think about it. The reason I say that is when I worked in Pittsburgh, I worked with a guy named David Kelly. They were interested in all the metabolic complications of the metabolic syndrome and such. And they got together with a guy named Ted Goodfriend, and he measured aldosterone in a lot of their patients and connected it with DEXA findings. And there's a very striking correlation between visceral fat and aldosterone, not in hyperaldo patients, but perfectly in normals. And it's raised a very large literature to suggest that the bilateral hyperplasia is partly due to the metabolic syndrome. And therefore, sleep apnea patients, of course, almost all have the metabolic syndrome. And rather than the hyperaldo causing the sleep apnea, I wonder whether a metabolic syndrome in sleep apnea is somehow predisposing to bilateral hyperplasia. And the paper he wrote, published in Obesity Research in 1999, has more than 100 citations. And I haven't followed that field especially carefully, but if you're particularly interested in pursuing that in some way, shape, or form, you know, the question is where has all that gone? You know, what are all those 100 citations about? And what exactly is the cause of bilateral hyperplasia? And is it somehow intertwined with something to do with the metabolic syndrome? So do you remember whether the connection was true both for hyperaldosteronism or hyperplasia, or not so? Or they just lump them all together?
I think they put them all together. I did not look specifically between adenoma and hyperplasia, But look into your question about causality. I've read that there's some investigator looking into, does sleep apnea somehow cause increased hyperaldosteronism stimulation and secretion because of like possibly stress, hypoxia, cause more hyperaldosteronism? But they did not get a good result because they tried to treat those patients with CPAP machine and tried to treat their sleep apnea, but did not show any drop in their aldosterone level.
Yeah.
So
well, I'm talking about other issues related to the
Yes.
metabolic syndrome, maybe independent of the sleep apnea issue itself. Yeah. So anyway, this is a common and interesting and important problem. So if you're really looking around for a project and want to study more, I'll direct you to Ted Goodfriend, Obesity Research, 1999, and I'm hiding at the end of that paper. So then it's extra special reason to look at it.
Yeah, thank you so much.
Yeah.
Thanks, Dr. Winters, for that information. It's very interesting. I didn't know much about that relationship, you know. It's interesting because I know for a long time we had been thinking similarly about cortisol adenomas, the adrenal nodules, and metabolic syndrome, and now there's a lot of noise about MACs and how they are linked. So I don't know about whether eventually we'll find something.